Okay, we're going to talk about chest tubes. And when it comes to chest tube insertion, there's a couple of reasons why a patient may need a chest tube insertion. A lot of the patients in Emerge who have suffered any kind of a thoracic injury may require a chest tube insertion. That's because they've suffered a pneumothorax, or perhaps it's a hemothorax where there is blood in the chest cavity. Perhaps there's been an injury to some of the great vessels off of the heart or chest itself. And so what happens as far as why do we need to know about this? Well, we do take x-rays, of course, post chest tube insertion. Take a chest x-ray to make sure the chest tube is in the correct location. However, there are occasions in the diagnostic imaging department where we ourselves, or the radiologists, will need to insert a chest tube. Okay, so if a biopsy is done, whether it's through ultrasound or through CT, as a common one is through CT, where a biopsy is done in thoracic cavity. What can potentially occur, even though the biopsy uses what's called a fine needle aspiration, what can sometimes occur is a pneumothorax. And a pneumothorax, of course, is where the lung collapses or what have you. And so what we need to do is we need to reinflate that lung. If a hemothorax was to occur in the diagnostic imaging department, then again, during some biopsy, and that would be in the lower chest cavity, perhaps a vessel, particularly an artery, was accidentally nicked. Okay, so biopsies are very planned and very strategic as far as the location and the angle and all that sort of thing, but sometimes these things happen. So if a chest tube does have to be inserted into the patient in the diagnostic imaging department, the radiologist will be responsible for doing that, okay? Because we have to ensure that pleural pressure is reestablished, okay? Because if there's an injury, then the thoracic cavity pressure itself has been changed. Now, before we kind of get into a little bit about where those chest tubes in the chest are located, what I'd like to do is just show you first off. This is an example of a chest tube set. Okay, it's just one of the examples. And on this chest tube set, it has a list of the different items that are contained in this set. So as we turn this over, I'm just going to kind of briefly walk you through sort of what you're looking at here. So we have a scalpel blade. Okay, we have the actual I guess you'd say the needle itself that will be inserted into the chest. We have what's called a guide wire, which has that red tip there, and as the name suggests, it's a guide wire. And then we have our dilators, okay? And the dilators help in a very civil manner to expand that area as we insert that chest tube in there. So we have a different needle here that we are going to use to freeze the location. So what will happen is the radiologist will put a little X with just a Sharpie on the location. Okay, the radiologist will freeze the area, and this is all done, of course, using surgical asepsis, so sterile technique and that sort of thing. Once that freezing is in place, okay, what they'll do is they'll take the scalpel blade and they'll just make a little nick. Okay, it's just a little nick. It's only a small little cut. And then from there, they will start inserting, as need be, the different size dilators. And the dilator itself, its purpose is to expand, okay, to expand that nick or that orifice that now we have created. So they'll use the different dilators. Now, as far as from a patient's perspective, this is not comfortable per se to have this done, particularly because of visceral the membranes in that can actually not be frozen, so we can't freeze everything, so unfortunately, but once the chest tube is inserted, the patients feel way better. I mean, now they have that pressure that has been reestablished. So what's going to happen is that once the radiologist feels as though they have dilated that little cut they have made in the thoracic cavity, then they're going to insert this, I guess you could say this tube or this needle itself. It's a tube that has, I can't remember the exact name of it, and I should look, but anyways, what they want to do is they want to place this in the correct location. So once the final dilator is used, they're going to take the guide wire and they're going to thread the guide wire through the dilator. The dilator will come off, and then the guide wire, as the name suggests, will stay in place. And then they'll feed this last sort of needle, catheter over the guide wire. The guide wire will then hold that in place, and then that's when they make the puncture. When they do this insertion, it's kind of got a pop to it. Okay, so they put it in, and then they can feel actually when they've entered the thoracic cavity. So you'll see that kind of motion or what have you as they've entered the cavity, and right away they'll start to get the air. Okay, you'll start to get air, or you start to get blood up there. Once we have that chest tube inserted, right, it's going to be hooked up to it's a water sealed chest tube drainage unit. And so this is, there we go. So this is something that we would come across now after the x-ray has been done. So the insertion tube, and I have one here, for example. So this is a flexible tube. So the big needle part would come out. This is the flexible tube that would be left in the patient, okay? All right, and transparent again too, so we can see if we're collecting blood or what have you. It would be hooked up, it would actually be hooked up to this tubing here, okay? So there's quite a bit of length on this tubing. But this is where, as technologists, we have to be careful when we're handling these chest tubes, because we don't want to dislodge or pull or accidentally yank on any of this tubing per se. These drainage units, will come down with these hooks, okay? So these units will hang below the area of the insertion site, okay? And a lot of stretchers, and I even have one here, I don't know if I have one on here, but a lot of stretchers will actually have a bar, and that is a designated location to hang the chest tube down below the stretcher, okay? We want to make sure that when we are transferring the patient, that we take the drainage unit with us, okay? Now, the drainage unit does have these little feet. In this case, this one's kind of it's not the most highest tech, but they have these feet underneath here, and often they'll be a blue color. And they're just a slide mechanism. You can actually slide it, and then that provides a base of support. Okay, so the chest tube can be placed safely and properly on the floor by the X-ray table or the CT table or what have you, just by using these feet. So if it comes without the feet out, that's because you don't want to break or crack the feet, but you'll have to, use the feet. I don't know if you guys can actually see that. Maybe you'll have to remove the feet and place them so that now this can be safely stabilized on the floor. Okay, all right. One of the other things too is that when these patients come down, give me just a moment. I'm going to grab one more little thing here. Okay, sorry, I'm back. One more thing I just want to point out here is when you see tape that is sort of a flesh color, this is a waterproof tape. It's really adhesive, and this is what's going to be used to connect, to connect the end of the chest tube drainage system with the chest tube itself. Okay, so this is where that waterproof tape would be used. This is also the tape that is used to secure the chest tube to the patient's chest as well, to the skin as well. So whenever you see this, chances are there's an indication that there's fluid around. It could also be used down, so when a urinary catheter is used or what have you. So this flesh-colored tape is considered the waterproof tape. Okay, all right. So what happens here is we need to understand that when these patients come down, we shouldn't hear any hissing or any sounds from this closed chest tube drainage system. Okay, if you kind of hear, it's like a bicycle tire. If you start to hear air, something's not right. There's something wrong with one of the connection pieces or what have you. It is no longer a sealed system. Okay, it happens. Okay, the point is how it happened. Well, we don't, that's not what we're trying to figure out. We're trying to fix it. Okay, so it might be something where we have to phone over to Emerge, or we might have to perhaps call the unit or have the DI nurse have a look at it per se. But you should not hear this chest tube system because it's a closed system. Okay, now where the chest tubes are placed, it depends on. So hemothorax has air. Pneumothorax has air. Hemothorax has blood. So what we want to look at here, just on this little kind of diagram here. So when we talk about if it's a pneumothorax, so if we're talking about air, and this is where we're going to use that good old thing called gravity. Okay, we're going to use that good old thing called gravity. If we're looking at a pneumothorax, the chest tube, and this is how you can tell. It's like, oh, is it a pneumothorax or a hemothorax? This is where you can tell. Air rises, right? We have our glass of water. Okay, we have our glass of water, right? Fluid, right? Versus air. Okay? And when it comes to chest tube insertions, what'll happen is that, and the reason why I'm letting you know this is for a couple of reasons. It's so you know when this has to be performed in, say, the x-ray department, what kind of position the patient has to be in so we can prep that patient for this chest tube insertion. Okay, so if it's air, okay, air rises. Let's keep in mind, like, we're talking about the patient being erect, okay? We're talking about the patient being erect. So air rises. So if the chest tube, if we're looking to treat in pneumothorax, it's going to be inserted in the anterior part, okay? I put that on there too quick. It's going to be inserted in the anterior part because if the patient is supine, okay, if the patient is supine, the air will rise. Sorry, you guys. Okay, the air will rise. So the chest tube will be effective when they're lying supine because the air will rise. We also want the chest tube to be inserted, if it's a pneumothorax, into the superior part of the chest so that when the patient is erect or upright, okay, again, to the superior part of the chest will be where the air is filled. Okay, so this is air. Okay, all right. So they're lying down, they're lying down supine, okay, air comes anteriorly. They're upright, okay, they're erect, air rises superiorly. Compared to if we are looking at a hemothorax, then we have to say to ourselves, okay, now the chest tube, because the hemothorax is different, now the chest tube is going to be inserted in the posterior part of the chest, because as we lie down, gravity is going to make sure that the fluid is in the most distal part. And now when we're looking at an upright projection, then we're going to say to ourselves, okay, yeah, now we actually have fluid or hemothorax in that right location as well. Okay, all right, so just the location of the chest tubes will let you know kind of what's going on with that patient. Please make sure you wear gloves when you're handling them. Please make sure that, it's important to keep the patient's modesty and that sort of thing, but blankets and sheets and that sort of thing, we need to make sure that those chest tube, right, the chest tube itself is not hidden and could possibly be dislodged. These can get kinked, okay? And you might kind of go, well, how would that get kinked? A wheelchair, okay? A wheel of a wheelchair. These patients come down in a wheelchair, and they've got this big cumbersome unit hanging off their wheelchair, right? And it's very easy for them to get kicked. So please make sure that you are continuously inspecting and monitoring and making sure that these units are in place there. It happens when the transfer is occurring. Okay, it happens when the transfer is occurring. So these pre-assembled kits for these chest tubes will be located in the diagnostic imaging department. Usually it's over in among where angiography and CT and what have you are. However, so you're not, what I'm saying is you're not going to have to go running around trying to assemble this and know what's on that and what have you. It'll come just like as this one has. This is an example one, right? The pre-packaged, everything you kind of need to go type of thing. And so that's kind of something along the lines of your chest tube. But please, as a technologist, make sure, particularly during the transfer of these patients or, as you're moving them about, that you are well aware and conscientious as to where those are at all times, okay? Patients aren't really kind of, it's dark. It's dark in our rooms. It's easy to step on them, trip, whatever kind of thing. So just keep that in mind, okay? Thanks.